One of the things that we're bringing you on live at ERS is important presentations that have significant impact for practice. Sepsis is a problem that's of huge significance to pulmonologists and intensivists, and there's been a good session this morning, and I'm delighted to involve Cesare Gregoretti from Palermo, and there were the 2016 guidelines on sepsis, and they've now been updated. Tell me what's new and what was talked about in your session.
Thank you so much for the question. Thank you so much for having invited me to talk about the recommendation that the sepsis guideline gave in 2016 regarding the use of mechanical ventilation of patients with sepsis affected by acute respiratory distress syndrome and by acute respiratory failure of consequence. Interestingly, not a lot of things change since the publication of the guideline, but I think that we need to make a point on two important issues. The first important issue is that even the guideline gave a lot of recommendations, not only for mechanical ventilation, but also in other, they cover other fields as how much liquid you have to infuse, hemodynamics, antibiotic, etc. I think, and we're reasoning that some of these recommendations really, they couldn't be applied in the real life, especially in the low-income countries, as India or Asia. And so we try to give the audience some information of how to behave in this setting. For example, the guideline in 2006 give no recommendation of using non-invasive ventilation in patients affected by ERS and sepsis. And interestingly, also the non-invasive guideline published in co-sharing between European Respiratory Society and American Thoracic Society give no recommendation of using non-invasive ventilation in hypoxemic failure affected by acute respiratory failure. I understand, and we understand, that there is a rationale behind this, because when the patient is affected by hypoxemic respiratory failure, and especially by acute de novo respiratory failure, what means acute de novo? Acute de novo means that today we are completely healthy, and tomorrow we get H1N1 influenza, so we get an ERS that can be defined as de novo respiratory failure. So in this case, if we became hypoxemic and we are breathing at a high respiratory rates, we can generate during high respiratory rate and high respiratory drive a high amount of transpulmonary pressure. Transpulmonary pressure is the pressure generated by our respiratory muscle. This pressure could potentially generate higher tidal volume, and this higher tidal volume can generate what is called self-induced lung injury. In other words, the patient is killing himself. So it has been argued that during non-invasive ventilation, you can increase transpulmonary pressure and you can increase tidal volume, because you have to add to the transpulmonary pressure that the patient is generated, the pressure that is generated by the mechanical ventilator during non-invasive ventilation.
One of the things that we're looking at in the session that you were in is the changes that have taken place since the 2016 guidelines on sepsis. So what's new?
Okay, thank you very much for the question. Thank you very much for inviting me to this interview. The information we try to give to the readers in the session we had this morning, if the sepsis guideline published in 2006 give really recommendation also applicable in the clinical setting, also of countries that have a low income. What does it mean? They give a lot of recommendation in different fields, covering hemodynamics, covering the amount of fluids, covering antibiotics, and also covering mechanical ventilation. The important issue, the question was, are all these recommendations applicable in the real life and also in all the income country? So I tried to address this question in the field of mechanical ventilation, and I tried to focus of the use, whether or not, of non-invasive ventilation in patients with acute respiratory failure and sepsis. And I think that this is an important topic because the guideline gave no recommendation, and also the recent guideline publishing co-sharing between European Respiratory Society and American Respiratory Society gave no recommendation for hypoxemic respiratory failure. I mean, especially for acute de novo respiratory failure. They are the patients that today are normal, with normal lungs, and tomorrow have sick lung. So, we tried, even this recommendation gave no recommendation to try a rationale for still using non-invasive ventilation, maybe coupled with high-flow nasal therapy in this field.
So are we going to use mechanical ventilation? Is it in, is it out?
I think that absolutely still in. If you go to see the online presentation, okay, you will see that there is still a rationale of using non-invasive ventilation in sepsis, especially in high-dependent respiratory units.
Terrific, thank you very much. So, particularly if you're a pulmonologist or intensivist from a low-income country, strong advice there to go and have a look at this presentation online, and you can find it on live at ERS+. Lots more to follow.